Following femto CCC, there is a change in technique for IA compared to manual CCC. In manual CCC, one can easily notice the free-floating fibrils of the cortex beyond the margin of the CCC, which are aspirated with the solid straight coaxial IA. With the invent of the femto CCC, there is a change in technique for IA. With the aspirating port, one has to reach below the CCC margin, grasp the edge of the cortex, take care that the anterior capsule margin is not held, and aspirate the cortex to complete and perform the IA. Notice the edge of the CCC. In flax, the rhexis size or the height of the resection can be adjusted from 600 microns to 700 microns or 800 microns, or even 1 millimeter above the CCC. We normally keep it at 600 microns, so it's 400 microns above and 200 microns below the anterior capsule. Post-flax, let us see the anterior segment OCT, where we see a free-floating CCC and a free-floating disc of cortex of 200 microns. In this case of a femto CCC, notice a disc of 200 microns of free-floating cortical matter, which is now being actually elevated and separated with the help of the viscoelastic. So there are no free-floating fibrils below the CCC, which are seen in manual CCC. So the technique changed for IA, which is essential but subtle. Post-flax, to perform bimanual IA in a well-dilated pupil, one can easily hold the cortical matter just below the margin of the anterior capsule and aspirate the cortex. Let's look at a case of flax in a very hard cataract. During phacoemulsification, the pupil constricts below the margin of the CCC. So now the problem begins. Here we are using the irrigating cannula to hold the constricted iris away, but due to poor grip, it keeps slipping and makes it difficult to do cortical aspiration. Look at the struggle, and the iris keeps slipping. One can use a solid coaxial IA and use a Y in the other hand to retract the iris, hold the cortical matter and aspirate it, but it is difficult to access all the corners of the bag in such a technique. So we invented the irrigating Y. To the irrigating handle, we attached an attachment like a Y, and this attachment actually helps to hold the iris away. With the aspirating port, we can go beneath the margin of the CCC, hold the edge of the cortex and aspirate it. The design of the irrigating Y is in such a fashion that the PC is kept away because of the flow. The procedure continues. Again, the iris is held with the Y portion of the irrigating handle and the cortex is easily aspirated. With change of hands, the procedure is repeated, iris is gently retracted, the anterior capsule margin is visualized and the cortex is aspirated. The beauty of this design is to be able to access the entire capsular bag all around. While going across, retract the iris, visualize the cortical matter and then aspirate it safely. One can access 180 degrees all around. With the change of hands, the irrigating Y can cover the other 180 degrees of the eye. In conclusion, the irrigating Y is a very useful instrument for an atraumatic retraction of the iris and aspiration of the cortical matter by avoiding the use of iris hooks in a non-dilating pupil or an intra-op miosis. Alternative uses are feeding the aspirating port, residual cortical aspiration after IOL implantation, facilitates hydroimplantation of IOL to guide the leading haptic into the bag, help to lift the IOL, support it and clear the viscoelastic from behind the IOL, maintaining toric alignment by pressure on the IOL during viscoelastic removal.